patients who we both struggled with at the beginning, looking at trying to treat their pain, trying to treat their substance use disorder, just overall how to do this and how to do it safely. And throughout that time, we recognized themes and what we were seeing and how we were seeing them and connecting with other people. During my time at WVU, I connected with Dr. Sedney and Dr. Singh, and I haven't had the pleasure to meet Patricia yet because we just haven't had time to connect through COVID. Dr. Sedney's work is more substance use disorder based, and she's done a lot of qualitative research. And Sarah was the main author on our previous publication at looking at oral morphine equivalents in patients with and without substance use disorder who had a concurrent diagnosis of cancer, showing that patients with a substance use disorder were more likely to get less oral morphine equivalents than their counterparts. So after that work was done, we decided we want to know why, and if the charts show that verbally or in the written form on any stigma, on anything like that. So this article is Stigmatizing Language Expressed Towards Individuals with Current or Previous OUD who have pain and cancer, a qualitative study. So one thing to note, since this is our first MAPPIT of the year, we try to use patient-centered language, saying this is a patient with pain, this is a patient with cancer, not having their diagnosis define them. So throughout this article discussion, please notice what surprises you about the findings? What are your questions arising from the paper? What would you see as next steps from this paper? What do you want to know about? And how will this affect your practice going forward? Just have those questions in your mind as we move forward. So I know that this isn't in the article, but I thought that this was really important to note here, because this is the framework that we used to be able to look at the patient records. This is the framework, and I wanted to share actually part of the article here, because I thought that this was the easiest way to see this. When we look at a health condition, we think of the health conditions as something that may define or is part of a patient. We don't want to define them by their illness, but sometimes that's how the stigma works. So one of the health conditions is leprosy that they have. They have drivers and facilitators, intersecting stigmas, manifestation, outcomes, so affected populations, and the outcomes for the organization and the impacts. So when we think of drivers, we think of things that worry patients. So fear of social exclusion, fear of disfigurement. So those are the drivers that make people with and without leprosy be worried about leprosy, stigmatizing. So facilitators, they're not used to, people affected by leprosy have lower socioeconomic status. So this is a facilitator. They're not used to speaking up for themselves. Intersections. So the intersecting stigmas are things other than the leprosy that are affecting it. So gender, ethnic background, and other societies. Then manifestations. So how do these things get affected? What are the things that come out of this stigma? So they lose their status, their reputation, they face restrictions in social participation, and there's negative attitudes and stereotypes and prejudice. And it's also a very visible illness. Concealment may cause delay in care. So this is the outcomes for the affected population. So it causes delay in care, poor treatment, poor adherence, poor treatment outcomes. So for outcomes, institution and organization based. So working with people with leprosy is unpopular. So it's really hard to find staff to treat these patients. And also this might lead to poor quality of service. And this again then impacts, so what is the overall impact? Reduced mental health well-being, depression, anxiety. Going back to the presentation here. Having trouble, okay. So when we look at this article specifically, what did we do? What were the basic characteristics of the patients? We had 25 charts to review, 64% male, 36% female. The ECOG scores are are similar, 0 to 1, 44%, and 2 to 4, 44%. Smokers, yes, 72%. And most patients were actually on admission 1 for their cancer-related pain. Pre-admission follow-up with pain specialists. So this is something interesting. So we only found that 8 of the 25 patients had a pre-admission follow-up with a pain specialist. Of note, the primary tumor site varied greatly. The disease extent also varied. So since we are a group that focuses on pain and palliative care and on addiction, I wanted to note the Karnofsky and the ECOG performance statuses and just have them side by side for you to read. The Karnofsky performance status is more palliative care oriented. The ECOG is more in the cancer world. So when we're thinking of these, how do they impact us? So they give us an overall idea of how the patient's daily life looks like, but also when we look at how we can put them into practice with prognosticating and how to get people resources, I wanted to show you the Karnofsky survival index. So this one only goes to 60 days. So 60 days is about a year survival. And a KPS less than that has a shorter life expectancy on average. This can get more complicated through newer therapies now. So in our article, we noticed themes, 4 themes, and I wanted to give some examples with that too. So themes, stigma drivers such as blame, stereotyping were present in the medical chart when contextualizing pain with OUD and cancer-related pain. So the patients were characterized by their history of substance use disorder. So when you look at patient does have a history of amphetamine, benzodiazepine, and opiate abuse. Or another example was patient with a history of IV drug use was also part of that opening quote in the H&P of the patient's chart, even though it had nothing to do with their current admission. And she was constantly asking for pain medication during her hospital stay. Both are it doesn't sound great, right? Stigma facilitators, such as legal or policy influences and non-care advocates could either be a positive or a negative determinant of pain care, as expressed in the medical chart. So family members or physicians can have a positive or a negative influence on how the patient is advocated for. So patient is denying any nausea or vomiting. She's denying any shortness of breath. She's asking for more pain medications at discharge. She has family and friends that are rallying for her pain medications at discharge. When we think back on our medical careers, we think of the patients' families that are more present, the patients who are less present, the patients who are more outspoken versus less outspoken. So think of a situation where you felt like the patient's family was was advocating for the patient versus a situation where you felt really uncomfortable in that room. So just notice the differences and think about how you approach the situation. OUD, or pain-related stigma, and other intersecting stigma impact medical care and pain control for patients with OUD and cancer. So this is this idea that pain has to be visible, or pain has to have an explanation. And so if we can't see it, then it must not be there. If there's no anatomical finding for it, it must not be there. And not having and making that a reason for not going up on the pain medications. So having a already made plan before you're talking with a patient. So the one interesting thing, and I think everyone has probably noticed this, when patients are cared for by physicians that are known within the healthcare environment, that have clout, have people that know that they are there to follow them and have constant communication with that patient, that will hopefully help improve pain care and help stop the stigma or decrease the stigma. Pain management was involved. Patient was discharged on 30 milligrams of Roxanol. She's scheduled with outpatient pain management. One thing to remember, these are chart reviews with direct quotes. Well, remember, narcotic isn't the correct description of opioids. Narcotic is a legal term and not a medical term. So we want to stay away from that. So I know my presentation was short because I really think that this article is able to think about and really help us think about what are we doing and what surprises you, what questions are arising from the paper. So I am going to stop sharing at this point, and I hope that we can discuss this a little bit in the last 10 minutes of the first half hour.
Yeah, thank you, Monika, for sharing your article. I know there's a lot of interest about how we document in the chart. One thing I wanted to ask you is how your team discussed how you were measuring the effectiveness of pain care. I noticed that one measure was the increase in like oral morphine equivalents. Mm-hmm. And I was just wondering about the background conversation about that.
So in the first article, we looked at oral morphine equivalents more than the pain scores, because it was an easier way to look at the chart overall to see if there were as many changes as with patients without a substance use disorder. So that was the best way to really exemplify the findings. And yeah. Kathleen?
Yeah, thank you. Thank you very much, Monika. I appreciate it. And I guess I was surprised for myself in the sense of like when you were talking about stigmatizing, like when we put like, you know, like an identifying, like this is a 45-year-old person with opioid use disorder or something like that, that you saw it as stigmatizing. Because I think about my own practice, that it is something that I might put in my identifying, because I'm kind of worried about the opposite, in the sense of like people getting admitted to the hospital and like they're totally ignoring the fact that we've had them on Suboxone, that they have significant I worry. I've gone the other way, like, oh great, you've put, you know, they come in and you've now put them on Oxy 30s, which was the reason that they got into trouble to begin with, and you discharge. So I think I've struggled the other way with some of my inpatient colleagues not paying attention and actually potentially causing harm by reintroducing what may have been the thing that got this person into trouble to begin with. So it was a kind of an interesting thing of like how to find that balance, because we don't, absolutely don't want people not to be treated, but we also don't want more harm done, when someone unknowingly, because they see, I've dealt more with the other side. Oh, they've got cancer. We can give them anything they want now, because I've had doctors say that to me, and I'm like going, well, no, their cancer is actually treatable and curable. And, so it was an interesting thing that I had to kind of think for myself, how to find that balance of not wanting to be stigmatizing, but also wanting to make sure that people are aware,
So the reason that we put this into the article was that there's good articles and good research done with patients with a substance use disorder, and noticing that those patients are consistently treated differently than others. So that's why we put it in. I agree. I think putting it somewhere in the chart is very important. So like putting it on the problem list, maybe not putting it as the first thing when we're doing our little patient descriptor, to not have that in the foreground, rather as another thing that's being treated, just like diabetes. But the problem is, as you said, it gets overlooked then, or it's not in the forefront of somebody's mind. I see you unmuted yourself, Sach.
Oh, no. Sorry, I'm going back to mute.
But I think it's that balance and finding that gray area and really advocating for the gray area. So Dr. McFarland, one way I would add this is a 66-year-old presenting with abdominal pain and nausea in the setting of gastric cancer and substance use disorder. I think that this is a really nice way to separate it, because when I think of writing my first blurb, and I've been just as a proponent of this without thinking about it, because in my mind it's really important for me because of what I do, but not having it. This is a 25-year-old woman with a history of substance use disorder, cervical cancer, anxiety, depression. Having it be like, this is a 25-year-old with cervical cancer and anxiety and depression who has a history of substance use disorder, not making it the primary thing when it's not the primary thing that we're talking about. I'd love to hear others' thoughts on what was surprising or what you're taking away from this.
Hi, Monica. Hi, everybody.
Hi, Anna.
Yeah, I think this is great. I think this is actually something that I'm thinking right now, and I want to take this opportunity because I know we have in the audience people in training, and even like myself when I was in residency and fellowship. I think when you said narcotics, right, it's not the legal, like the right word to say opioids, and it's just kind of like something that is so commonly used. Like I hear that every day, and I think it's part of our responsibility to educate other people, and because I think words matter, right? Words matter a lot, and I think it's part of the whole this idea of stigma. Monica, I wanted to ask you if you can just give us some examples of other words that are commonly used and what is like the right way to say it. Like I remember seeing another presentation a while ago, and some ideas come to my mind, and like I don't know, like when people say patients have been clean. I think that's not right to say, like commonly, as an example, how in healthcare we say withdrawal of care, that completely drives me crazy, right? It's not withdrawal of care, withdrawal of life-sustaining interventions, but that's something that is like constantly said in other, healthcare systems. And under the same example, like what are other things that you commonly say that it could be a good idea for education, for like people here in the audience, and even for myself as a reminder, perhaps, using substance use disorder instead of like IV drug use. Is that not right to that's one question I wanted to ask. If you can just give us some examples of like common things like terminology that is used every day and is wrong, and what would be like good terminology and why is that wrong? Like your example you said were narcotics.
Mm-hmm. So I feel like Katrina is more of an expert at this than I am, with her further training in addiction.
Yeah.
And I want to invite everybody like Susan Cohen to put their things that they've learned into the chat so that we can all learn from them. So
Thank
I'm
you.
going to hand it over to Katrina.
Yeah, no, that's a really good question. And that's why we wanted to start this academic year talking about stigmatizing language and just starting with the words that we're using as we document. That also helps us slow down and think about what the clinical diagnosis is in front of us, right? So yeah, first, like what's at the forefront, we talked about that, but terms that we would use, even being careful with saying substance use disorder, right? Because we might just have presence or absence of a substance on the urine drug test. Like that's one of the first things that I see on a chart is sometimes they'll say this is a patient with addiction or substance use disorder. And when you ask, that actually was never diagnosed. It's just there happened to be an admission ER urine drug test that was positive for like cocaine or positive for methamphetamine. And until you really diagnose it and go through the history and ask them about that to find out if it is just unhealthy use or is it a diagnosable disorder of substance use disorder. So that can be, I guess, correct me, somewhat of a facilitator if I'm using the themes correctly, but that could be a facilitator of stigma as well. So that's a very subtle one. The obvious ones would be like against medical advice, and instead saying, a patient-directed or self-directed discharge from the hospital, the narcotic. As far as IV use, I think the big concern is not using the word abuse, but using the word use, like someone has drug use history, not drug abuse. So that would be the first one to get rid of. And then when you're talking again about urine drug testing, that you're not saying clean or dirty, like just get rid of that. No, it's either positive for a substance or presence of a substance or absence of a substance or medication when you're trying to say what the urine drug test results were, or expected for prescribed medications and metabolites, or no presence of prescribed medications. And that would be another one. Another one that I see, sorry, in the article, but I would hope more what people would talk about is the word legitimate when we're talking about patients and patient care. Legitimate and legitimizing, right? Like we're basically saying that a patient report is not real when we're saying if it's legitimate, because withdrawal pain is extremely uncomfortable as well, and is it a negative experience, right? We know pain is a negative experience. So it's trying to steer away from saying legitimate pain, but maybe, especially as palliative care specialists, we're supposed to be able to say what kind of pain this is. Is this, a physical generator, nociceptive pain, neuropathic pain? Is this a total pain? But using the word legitimate or legitimizing pain would be another one that I would try to be mindful of in our conversations, in our documentation. Sorry, I see people putting a lot more in the chat.
Thank you. That's very helpful.
Oh, thanks. Yeah, for all of that. And then just to comment, Meg, pointing out the opioid dependence with the intention of opioid use disorder. That's tricky because sometimes we're trying to make a separation of somebody who's just having physical, like the physical symptoms in the context of like prescribed opioid pain management. And that one, actually, we should probably explore this year of separating that out of why is someone intentionally trying to make a difference between opioid dependence and opioid use disorder. It's almost what Kathleen's talking about of almost minimizing something, and so that we're missing things because we're so negatively feeling towards someone with an opioid use disorder as opposed to someone with prescribed pain. So